Jim. Thank you for asking me to be involved with this meeting. Now, it's my duty and pleasure to introduce Mary Gospodarowicz, who is the medical director of the cancer program at the Princess Margaret Hospital. She's a uniquely qualified person with qualifications in internal medicine, medical oncology, and radiation oncology. And she's going to talk to us from her vast experience about the importance of team building in oncology. Dr. Gospodarowicz.
Thank you very much, and thank you for the invitation. When I was asked to speak and I was asked to introduce the conference, talk about the benefits of multidisciplinary approach to cancer care, I thought that was easy. And then there were things that happened. I had other presentations, and then early this week I sort of looked at your website and I thought, wow, it's like carrying coals to Newcastle. You get it, you do it. And so I had to change a little bit of tack of what I was going to talk about. No, I didn't do my homework. This one? Forward? Okay. So cancer, everybody knows, the leading cause of death worldwide. And in 2007, there were close to 8 million cancer deaths. There are cancers some cancers that are very common, and at the present time, people who deal with population-based aspects of cancer think that about 30% of cancer deaths can be prevented right now if we just apply what we know, but we don't. Tobacco is the single most important risk factors for cancer, but more and more infections, especially viral infections, are, and if we just applied our knowledge, we could be further ahead. And it is estimated that unless we do something about it and start applying our knowledge to cancer prevention, early detection, and cure, in 2030 there will be 12 million cancer deaths worldwide. But when people talk about cancer, they talk about the big four, the big five, and the particular program is that of orphan cancers. Orphan cancers are rare cancers where nobody actually has quite the number of cases to bring it to people's attention. And I think that's one of the that you're facing. And there are documents and books written worldwide about what optimal cancer care is. We know it. First of all, to have it, you need a comprehensive set of population-based programs in early detection and diagnostic structure. You need high-quality healthcare interventions with multidisciplinary and increasingly multi-professional teams. To provide right care at the right time by the right team to the right patients. That requires acceptance of certain standards. In medicine, there are practice guidelines and standards. It needs adequate education training to provide adequate healthcare professionals and knowledge transfer, and obviously research and innovation, otherwise we wouldn't be making any progress. So most of you are younger, but growing up, there was this guy who was called Dr. Welby, who was on television, and he had this little black bag, and that's all he needed. He could diagnose anything he wanted and cure everybody, and he provided patient care. And he had some young scientists that he was training, but that was it. Now, we know that we need specialty expertise. There are many disciplines, the surgical oncologist, radiation oncologist, medical oncologist, oncologists. There's subspecialty expertise. I treat lymphomas. Lymphomas can occur anywhere in the body. If I want to have a head and neck lymphoma, I go to head and neck radiologist, chest radiologist. I need to go to 4 people to gather expert opinion. In imaging, there are specialties of nuclear medicine and MR and other diagnostic modalities. Pathology is you no longer need a pathologist. You need subspecialist expert pathology, not only in cancer, but in specific cancers. And there are constant of new specialties. I was talking to Sylvia earlier. In my early career, I was undifferentiated. I was treating actually gynecological cancers, lymphomas, GU, endocrine cancers, and as everybody else, I differentiated these things to treat only a couple of areas. Because if you have If you want to have a depth of expertise, you can't have it goes. And even nursing is becoming more complex, and there are expert nurses and expert pharmacists. So the team is more complex right now, and the teams should work together, but it should beautifully work together like that, great degree of cohesive expertise, safety, but sometimes they work like that. They just don't quite get the work done. And there are numerous barriers to cancer control when you think about the whole spectrum of cancer. They could be economic, they could be organizational, they're also cultural. We are actually lucky in America that the cultural barriers are relatively minor. But parts of the world where people hearing the word cancer, they're ashamed of having this disease, and trying to improve the diagnosis and cure of cancer in those jurisdictions. Huge barriers, because if you can't get patients and public as your partners, you usually fail. Julie Gebberding, who was previous director of Center for Disease Control in States, talked about the barriers to implementing and having progress in healthcare. And she classified them into 3 C's. One was complacency. And complacency is prevalent also in our country. It is the healthcare system is underfunded, it's not good enough, we need to change it, blame the government, blame somebody else, and don't look in your own institution of how you can change and improve things. And there's resistance to change. We want to implement something new, and that resistance to change is at the level of the government, sometimes not even at the level of the hospital, sometimes at the level of our colleagues. And we all got used to the fact that it can be done tomorrow. So, especially in Canada, there's this total lack of urgency. And I think the best partners that we have in engendering the sense of urgency in the healthcare system and the hospitals and the professionals are patients, because patients are at the receiving end. The second C is capacity. Unless you build capacity in the system, enough healthcare workers, enough resources, you can't have good access. And I think this building of capacity needs to be multidimensional. It's not all about opening beds. It's not all about hospitals. It's multidimensional. It includes all kinds of professionals. We can't just expect to get more and more money into the system. We have to figure out how to do things smarter and better and make them affordable. And the third C she talked about is connectivity. How do we make sure that we don't repeat things? How do we make sure that the knowledge is transferred and there's some big kernel of knowledge that it becomes available to everybody? And how do we build and use modern information system to allow us to overcome this barrier? And I would submit, and I think most people in the room would submit, that the progress is very slow. We live in a very fast world, and the things that are getting better are too slow, and we need to create a sense of urgency to make them faster. It was Albert Einstein who said that insanity is doing the same thing over and over again and expecting different results. And I would submit that we are doing things the same way all along. An opportunity. We've all witnessed the information communication technologies, so-called ICTs, and I think there's no doubt that the growth of ICTs has been greatly used by the banking industry, financial sector, travel. You don't no longer go to a travel agent, you go online, you have information, you have fingertips, and it's used. But the healthcare has been very slow in adopting that. And there are a number of areas where it's good. And look, I went on Google last night, neuroendocrine tumors, 348,000 hits in 0.09 seconds. That's access to knowledge, that's access to information. Harnessing it, are we benefiting from it? So we live in a network world, and this network world will redefine health. And then you have to be sympathetic to your doctor. This cartoon says the patients know more about their diseases than me. I must get faster, modern, access than them. But maybe you don't. Maybe you can learn from your patients. One of my colleagues, who is actually in the University of Network, Gunter Eisenbach, has been working in the area of e-health and has not worked with e-health Ontario, so relax, please. And he actually is author of one of the seminal papers on the change in the medicine and in information age. The industrial age medicine was based on hospital medicine, disease management, provider-oriented medical informatics, so you just listen to your doctor, whatever told you, and that was it, and focused on traditional medical informatics. With the change to information age care, we have a transfer to ambulatory care medicine, medicine, cyber medicine, from disease management to self-care to prevention and health, and the growth of what he calls consumer health informatics. At the same time, while he's talking about Web 1, we have a huge revolution from Web 1, which is mostly read-only web, small number of sites, published contents, about 13 years ago, 45 million global users, to Web 2, where you have millions of sites. There's still a lot of published content, but much more user-generated content. So the Web 2, it goes around from the providers to the receivers and then back to the providers. And there is a new term coined by people, actually one of them Canadian in Ottawa, Mark Tolley, the term collective intelligence. If you just put together the knowledge and the wisdom of everybody in the city, in the hospital, in the country, planet, we could probably create progress, accelerate progress to the unprecedented before extent. Because we do live in this network world where everybody is connected to everybody very quickly. And this is due to internet. Somebody wrote a number of years ago doing studies, is a perfect tool for collaboration. And the reason for that is actually a tool that no one controls. No one can turn it off. It's just there. It serves everybody. It's very open. It's a great equalizer. It provides the means to share works and ideas, diversifying, centralizing. No one owns it. It's always turned on. It's empowering. It's a publishing machine, innovation machine. It's a marketplace and connects communities. So when you start thinking about opportunities, they're humongous. And the penetration is huge. This is as of now, 2009. 73.9% of population of have access to the internet. Now it's less in Africa, but even in Africa, there are 65 million users of the internet. In North America, in Asia, 704, in Europe, 402. In North America, 251 million people use the internet. So if you think of how you can reach the population, here's your answer. Now, why should we collaborate? This is not from medicine, this is from business. This is the economist called Prahalat, who works in the University of Michigan. He wrote a book, many of you could have read it, from the bottom of the pyramid. And he asked the question, why collaborate? And that's the quote that he wrote. And he said, if you stop thinking of people as victims or as a burden and start recognizing them as resilient and creative entrepreneurs and value-conscious consumers, a whole new world of opportunity will open. So I'm asking a question, who are the poor in cancer? Who are the poor that if we engage them, we can open the whole new world of opportunity? Part of my hobby, this is not my work, this is my sort of Boy Scouts engagement, is to work for UICC. UICC is an international union of cancer with a vision where cancer is eliminated as major life-threatening disease for future generations. It's a huge, huge toll. But the main mission of UICC is to build a community, cancer control community, and it's actually probably the only organization that has amongst themselves, it's an organization of organizations. But the organizations could be cancer centers, could be ministries, could be professional societies, could be research societies, could be patients groups, could be cancer control organizations, could be cancer leagues, cancer societies, any organization can belong. Now, it's a huge challenge to make this minestrone soup of people work together because everybody has their own agenda, and it's going to take a little while for people to drop their agenda and work to the common goal because there's actually no shortage of work to be done when you think of the aim. So we are already participating in this network work. When I went on this website, I was very, very impressed. You are there, you're using the tools, and you're not alone. And then I'm going to bring a couple of other neuroendocrine carcinoid that says you're not alone websites, but also give you an example of the group that's been extremely progressive, the Life Raft group. I don't know, how many in the room know about Life Raft group? Somebody knows about them. Right. They're a very proactive group. They're a group of patients with GIST, gastrointestinal stromal tumor. And when the industry was developing the drug for the disease, that group actually contributed and organized and contributed and attracted patients to clinical trial, the clinical trial that really led to the use of Gleevec in this disease. So the patients with the disease became partners in research and partners of developing new therapies. A very progressive group. It's led by patients. Here's another group. I treat testicular cancer, and I've been very impressed. I work together with this group. It's led by the past patient. And this is a website for patients with testicular cancer. It's a cancer that is prevalent in very young men. It's highly curable, but it's a rare disease. So if you are in a small center, how do you access the expertise? And this group is a mediator between the healthcare professionals and the patients. So I would get an email or a phone call, usually an email from the moderator of the group. He said, somewhere in a small town in the UK, there's this patient who didn't understand why this and this and this. Now, the moderator has deep knowledge about the treatment and about this disease and probably answers 75 to 80% of queries, but there's something he doesn't understand. He has created a network of experts worldwide, in Canada, in Australia, and Europe, and everywhere. So he can actually email me and say, do you know where this patient can go in the UK, somewhere close, to access the expertise because things don't sound right. So suddenly, this patient who is there alone in little small town can access the expertise. This website is out of, I think, Chicago, somewhere in the States, to access the expertise from Toronto to guide them to the treatment. This is done free with no cost with volunteers. So there are ways that patients, organizations working with the professionals together can move forward the research agenda, can move forward and improve the quality of care. At Princess Margaret Hospital, we have started looking at this engagement because we believe that fundamentally you can actually use the computer and use information communication technology to actually treat patients and help patients. So we have established a site called Caring Voices. This is a research initiative. This is funded entirely from our Walk to End Breast Cancer because it's not funded, there are no funding mechanisms for these initiatives otherwise. And since we had this big walk, people started doing it for breast cancer, but now Caring Voices is available to any group of patients, and not only in Toronto, but anywhere in the world if they connect. And what the site is trying to do is to go a step further and partner with patient organizations and with patients to not only provide the information about where to go for care, but maybe provide support and direct patient to another patient, so team up the patients, provide moderation of the debates on both research and treatment, and somehow facilitate the conversation between the healthcare providers and the patient groups. This is an experiment because I reckon we still don't know what's the best way of engaging with the communities of practice between the experts and the recipients. So there's a number of individuals who actually do research to see what works the best. And we were recipients a couple of years ago for Canada Foundation of Innovation multi-million grant to have a physical facility built to put infrastructure, both for the web communication, computer infrastructure, but also a small area where we can host patient groups or community support and provide different means of support for a different group of patients. So this is work in progress, experiments, but if you want to engage, I can direct you to where to go. So I put before that this was now, but I don't think this is now anymore. I think the right team now includes a patient. And we think of cancer as the interaction between the patient and their oncologist. But that's not it. You have to put the primary care physicians in. If you don't have your primary care physicians, then you never get to that specialist. So the team right now is patients with their primary care physician and nurse, all their specialists, their pharmacist, social worker, and huge personal support, social support networks. We all live in the area of social networks, whether you're part of Facebook or MySpace or others. I know that it's a bit of a generation thing, but I think more and more people of all ages engage and use these networks so they can not only be supported by family and friends, but also have online support network. So I'm an optimist because I believe that any cancer doctor needs to be an optimist or they should get out of the business. So I think, what if all my colleagues and all the oncologists were part of a worldwide network and they had access to best diagnostic tools, had support, and the patients had support with asynchronous consultation. Let me spend just 1 minute to say, physicians in the big centers do something that's called corridor consultation. They meet each other in corridors. If I had a patient who was difficult, it's unusual, what do I do? And you meet 3 people and suddenly you're smarter. What do you do if you don't work in the same institution? You could develop an online asynchronous consultation where you post it online together with pathology, with imaging information. You have a 24/7, 365 network of experts who would say, oh, I think this is this, oh, I think this is unusual, and provide collective wisdom, this collective intelligence to help solve difficult cases. What if patients had support in their advocacy role? What if everybody had access to online education of their younger colleagues? What if we all partner with patients and public? And what if everybody exchanged the knowledge and of what works, not only on what drug to use, but what interventions work worldwide? It's actually Barack Obama who defined now, and he made it actually very popular to say the way things are. So he said there are 2 worlds. There's the world the way it is, and then there's the world the way it should be. And there's a gap. And our usual approach to the gap is to find some leader like him or somebody to fix it. I think we all know now that there's no one person that can fix it. It takes everyone. And everybody has to do their own bit to fix it, to fix this gap. And there's no reason then why we couldn't have the world as it should be rather than the world that it is. So this is my sort of line. I think that anyone who thinks the sky is the limit has limited imagination, and I think you probably believe it too. So thank you very much for your attention. I just wanted to acknowledge some of my colleagues who make me think differently. Thank you.